Well, first of all, I just want to say good afternoon to everyone. It's, again, as I said, it's an honor to be here. As Eric Israelian mentioned, my name is Fola May. I'm a gastroenterologist and health services researcher. I work at UCLA Health and in the VA, and in my lab, we focus basically on cancer prevention control for GI malignancies with a focus on colorectal cancer. And also we have a huge focus on in our group, which is just reducing disparities in health care and health outcomes for individuals who have GI cancers. The title of my talk today is White Coats for Black Lives, Racial Inequities in Health and Healthcare. These are my disclosures. My hope today is to provide definitions of equity and disparities in health and healthcare and examples of inequities by race and ethnicity. We'll also discuss contributors to racial and ethnic disparities and pathways to eliminate racial and ethnic disparities in health and healthcare. We'll start with a quick primer on equality and equity. So I really love this infographic. It's a visual representation of the concepts of equality and equity. And in this infographic, the concept is that we are all trying to get somewhere. And as you can see in the top panel here, everyone, regardless of need, is given the same bicycle to get there. This is the concept of equality, that everyone gets the exact same supports. The contrast is the bottom panel. In the bottom panel, everyone is getting the support that they need to get there. The concept of equality is that everyone deserves to achieve the same goal, but as in this bicycle analogy, one size does not fit all. So when we translate that to health and healthcare, health equity is the attainment of the highest level of health for all members of the population. And when we talk about health disparities, those are differences in health and health outcomes that are closely linked with economic, social, or environmental disadvantage. There are countless examples of inequities by race and ethnicity in the United States. And these disparities do not spare children, and they actually start at birth. So as you can see from these data here from the National Center of Health Statistics, we have a higher rate of neonatal and postnatal mortality among Black children than among white children in this country. There are also very disturbing disparities and differences in maternal death rates that have been recognized in the literature. Again, data from the National Center for Health Statistics shows that Black women in the United States die 2 times more likely than white women or Hispanic women in the United States as the result of pregnancy-related causes. And this has actually gained a lot of attention over time, and even more so more recently in light of current events. These disparities that we see do not end with childhood or with pregnancy. They actually extend to the end of life as well. And this graphic here shows deaths per 100,000 people in the United States by age group. The Black Americans in our country are represented by the burgundy bars, and they have a higher mortality for any age group compared to whites. So in other words, Blacks are more likely to die at all early ages from all causes. As we have seen this year with COVID-19, differences in health outcome also occur with acute health crises. So in the pandemic, Black Americans have died at a rate that is 3 to 4 times higher than white Americans in the United States. And in reality, the pandemic has shown a bright light on the racial and ethnic disparities that we see in our country throughout many different health outcomes. And for many of us who work in the field of health equity, it has amplified the importance of our work. So what about our field specifically? What about GI and hepatology? As summarized here in this one slide, the disparities in health outcomes in GIs and hepatology actually span from the esophagus to the rectum. And for some of these conditions, most importantly, some of these malignancies, the disparities are in incidence, so likelihood of getting the disease, or mortality, while in other conditions like IBD, liver transplantation, the differences are in disease management, access to care, and access to specialty care. One of my primary research focuses is in colorectal cancer screening and colorectal cancer outcomes. In our group, we look at everything from the epidemiology of the disease to the implementation science of introducing interventions to improve screening rates in low income and ethnic and racially diverse populations. As many of us are aware, there are marked disparities by race and ethnicity in colorectal cancer. These are data from national cancer registries, and they highlight that there's a higher incidence in colorectal cancer in Blacks when compared to whites and other ethnic and racial groups in the United States. So Blacks in this graphic are represented by this teal bar and have the highest incidence when you look at men, women, or both sexes combined. This pattern is actually very similar for mortality. So Blacks have 40% higher mortality from colorectal cancer from white Americans. And as you can see here, overall, deaths are higher in Black Americans, and they're followed actually by Native Americans. And recently, American Indians or Native Americans have been getting increasing attention because they're one of the few groups that we're seeing rising incidence of colorectal cancer. Blacks and American Indians are followed by white Americans, followed by Hispanic or Latino Americans, and then followed by Asian Americans, which have significant rates of incidence and mortality from colorectal cancer, however, lower than the other ethnic and racial groups. In health equity research, rather than simply recognizing that there are differences in race by race and ethnicity, our major goal is to understand why these differences exist so that we can come up with interventions that help eliminate these disparities. Overwhelmingly, the evidence is that disparities are multifactorial, meaning that there are many contributors to any one health disparity. So rather than biologic or genetic differences between Blacks and whites, many of the disparities that we see in between Blacks and whites are the result of differences in things like employment, family income, the community that you live in addition to access to health services, and also just our behaviors, use of tobacco, alcohol, and other dietary factors. We like to think of these root causes of health disparities as social determinants of health. And I'm sure that everyone's been hearing a lot about social determinants of health in the last few months. And I like to think of social determinants of health in the analogy of a river, in that what happens in upstream in a river is going to have an effect on the downstream currents. So in this particular model, there are upstream determinants of health, midstream determinants of health, and downstream health outcomes. So upstream determinants of health are the macro social structural influences on health and health systems, their government policies, social, physical, environmental, and economic factors that impact our health. Midstream determinants are the result of these upstream determinants of health, and they mediate the impact of upstream determinants on the downstream health outcomes. And the downstream health outcomes are what we see in our hospitals and clinics. They are the health-related endpoints that result from the upstream and the midstream factors. So for example, you can look at upstream factors like racism and discrimination, which, as we're going to explore in a few minutes, can lead to differences in employment status, living environment, and food insecurity. And we all know that those things have downstream effects on chronic disease and cancer. So what is systemic or structural racism? Systemic and structural racism refers to racial inequities that occur as a product of institutional, historical, cultural, and interpersonal practices within a society that put one ethnic or social group at a better position to succeed, and it also at the same time disadvantages other groups. And what I want to do now is I want to share a few examples of how systemic racism is an upstream social determinant of health. And one of these examples actually comes from right here in southern Los Angeles, and it's this concept of redlining. For those of you who are not familiar with this concept, redlining is the discriminatory practice of purposefully denying mortgage loans to people based on race, ethnicity, or where they live. So historically, this practice targeted people of color, and it targeted people of color who live predominantly in minority communities. Even the US government has used redlining. There are several maps that have been captured that show the US government using red ink to label parts of major cities like Los Angeles, New York, Miami, Chicago, and they label these areas as whether they are worthy of investment or not. And many of those determinations on worthy of investment are based on the racial and ethnic composition of the region. So the map right here is actually a map from 1939, and it shows Los Angeles. And you can see here the government labeling of red areas as hazardous and yellow areas as definitely declining. And these labelings were highly correlated to the Black and brown, the density of Black and brown people in these areas at the time. So practices like this have actually crystallized things like lending discrimination. They've reinforced race-based bias in our country, even things like the quality of the schools in the neighborhood, the quality of the neighborhood itself, how close the housing projects are built to freeways, exposures to environmental toxins. A lot of these things are downstream effects from redlining that has happened in Los Angeles. And as we know, all of those things can impact our health outcomes. There are long-term impacts of these historical discriminations, and the next several slides talk about some of these long-term impacts. And the current inequities that we see in our country are actually a result of things like redlining, and they also are a propagation of that culture. So for many Americans, really the first time these inequities came to light was right after the murder of George Floyd, even though these things have roots that go all the way back to slavery, and even before that with the discovery of what we falsely call the New World. With George Floyd this summer, however, we had a roaring public discourse about inequalities, particularly between Blacks and whites in this country. We saw graphs like this that show that Black unemployment in America is historically higher than white unemployment. And that gap, as you can see towards the end of the slide over here, actually only got worse during the COVID-19 pandemic over the last years. We also know that Black workers have earned less for the same work than white workers. So in this graphic, we see the Black annual income as a percent of white annual income. In 2018, so on the right side of the slide, the average Black worker earned 62% of what the average white worker made in the same position. And quite honestly, that's not too much better than we were doing way back in 1967 when Blacks earned 59% of whites. The next examples are actually about differences in law enforcement. So marijuana usage is actually quite similar in white and Black Americans, yet Black Americans, as shown on the right side here, are 4 times more likely to become arrested on marijuana possession charges. And is highlighted by the civil unrest after the murder of George Floyd, Eric Garner, Breonna Taylor. Fatal police shootings in this country disproportionately kill Black Americans. In fact, Black Americans are 3 times more likely to die from a fatal police shooting than white Americans. So for those of us who work in the space of equity and health equity and who've been measuring the impact of race and ethnicity on health outcome for years, we begin to wonder, are we really measuring race? Or are we measuring racism? Because race is a social construct that we've really created by society and culture, where the reality is that many of these drivers are secondary to racism. And the distinction is critical. Distinction is critical because if it is in fact racism, there's actually a little bit of hope. We can actually define the mechanisms by which racism is occurring, and then we can design interventions to try and impede or interrupt those pathways that are leading to poor or worse health outcomes for certain groups. So I want to spend the next part of my talk, which is the last part of my talk, talking about how do we fix health disparities. And this exactly, I think, is the most important part because it's the way forward. To fix inequities in the United States, we must first acknowledge that they exist. So that was, pretty much the first part of my talk, was trying to impress on you that there are differences by race and ethnicity that have plagued communities since the beginning of this nation. And quite frankly, at that point, we can take a scientific approach to this problem. Once we acknowledge that there are inequities, we can then focus on identifying the mechanisms by which that they occur. And there are several studies out there, it's a whole separate presentation on the impact of things like exclusion, bias, disinvestments in low income and Black and brown communities, and access to care have led to inequities in health and health outcomes. Lastly, we can develop and disseminate solutions that address these disparities or these mechanisms that cause disparities. And we have learned from research that has been going on for decades that the best solutions are the solutions that are multimodal and multi-level. So what that means is that we're best at eliminating health disparities when we have interventions that address patient level, provider level, and system level contributors to the problem. And most of the work that we do in public health and in implementation science are doing exactly that. We're developing these multi-level interventions that are addressing issues like discrimination, racism, health inequities at the patient, provider, and system level. And it's that cumulative effect that can have an impact on eliminating disparities. Many of you have likely received training in the last few months or even before that on bias. And the concept here is that bias can help reduce the discrimination that we see in our healthcare systems. Implicit bias refers to the unconscious, unintentional assumptions that we make about other people that we see. And these are due to unconscious associations that we already have imprinted about different social groups. And that's very different than explicit bias, which we're going to call it what it is. It's frank racism. It's referring to the conscious, intentional opinions that we have developed about others. Now, these are important because we know that bias has an impact and a direct pathway to disparities. We know that implicit bias can lead to our changes in our clinical decisions. It also impacts our communication patterns with patients. This in turn can lead to poor understanding among patients. Patients also experience delays in care because of poor communications or the decisions that we sometimes make. There's avoidance of future care. And unfortunately, this also results in role modeling for the trainees that watch us exhibit these biases in the healthcare system. In turn, the downstream effect are the disparities that we see. And of course, there are other factors leading to these disparities, but we know that implicit bias plays a role. So our interventions then are far upstream and trying to find a way to interrupt this pathway. And if we can determine these mechanisms, then we can come up with interventions to reduce implicit bias so that we don't have the downstream effects. And that's exactly what these trainings are doing about implicit bias, is we're trying to teach healthcare providers how to be cognizant of these unfair judgments that we make so that they don't lead to these changes in how we provide care and health disparities further downstream. And there are data that implicit bias training does exactly that. So getting back to how we address inequities, and to do that, as I've alluded to, I think many things need to happen. And the first couple bullets here we've touched base on. the first step is increasing awareness of racial and ethnic disparities. And I'm sure that many of you have been aware of the differences that we see in health and health outcomes by race and ethnicity. But the reality is that many others in our own profession are not aware of these differences. And they're not aware that they span everything from GI to cardiology to primary care to surgery, pretty much existing in every field. So a lot of us have focused in health equity research on bringing awareness to these problems and how prevalent they are in our different fields. We've also talked a little bit about the importance of recognizing and stamping out implicit and explicit racism in healthcare through implicit bias curriculum development and implementation. And as I mentioned in the previous slide, this is an important step to reducing or eliminating the differences that we see in how we provide care for patients that are based on just how they look. The next thing that's going to be critical to address and reduce inequities in health and healthcare is support for research. So at the federal level and beyond, there is a need for funding dollars to understand and address racial and ethnic disparities. And these research studies also need to understand the relationship of social determinants of health to disparities. And that research usually comes in three phases. It's, as we've discussed, acknowledging that the disparities or finding the disparities that exist. Second phase being identify the mechanism by which the disparities are occurring. And the third phase, the implementation science side, is developing the interventions to solve the problem of the disparity. Representation in clinical trials is a big part of what's missing in the support via scientific investigation. So these are data from the Center for Information and Study on Clinical Research Participation. And it actually shows that although Black Americans are 13% of the US population, we only represent 5% of patients in clinical trials. This has come up as most recently with the COVID vaccine and development of that, in which many of the groups, including Moderna and Pfizer, have come up with specific strategies to try to make sure that they are enrolling a diverse subgroup of patients, which is critically important because, as we've already discussed, COVID disproportionately impacts certain racial and ethnic groups. So it's important for those people to be included in those trials. But this goes beyond COVID-19, and we're recognizing that in clinical trials in pharma, studies that are supported by the NIH and others, we don't do such a great job. Addressing inequities also requires us to increase representation of underrepresented doctors and researchers to reflect the diversity of the country. As I mentioned, African Americans are 13% of the US populace, but we are 5% of US physicians. And when you look at Black physicians in academic institutions who are professor roles, Black physicians are only 2% are only represented by 2%, which is exceedingly low. So a lot of the focus right now as well has been in STEM and increasing exposure to science and medicine early in life so that we have a larger pipeline of individuals that are entering science and medicine careers as a profession. And, you know, I like to point out, I mean, I think representation is important, but there's also data that representation matters. And there was a study that came out this summer that actually showed that when Black doctors are providing care for Black patients, there's less mortality. And that's a pretty significant finding. So this representation is important, not just because we want representations of different values and cultures and backgrounds, and we want people to do health equity work, but it's important because it does have a direct impact on health and on health care and also health outcomes. And mortality outcome is probably the strongest outcome that you can show and one of the most important. In addition to representation, there's also going to be a need for development and dissemination of solutions to increase access to high quality healthcare for all. So many people who are in the field of health equity as well are developing interventions to make sure that whether you live in a low income part of Los Angeles or in a high income part of Los Angeles, whether you live in a community that's mostly Black and brown or white, that you have access to high quality healthcare. We've learned from the Institute of Medicine report several years ago that quality of care matters. So if we don't have access to high quality care among ethnic and racial minorities, we can't achieve health equity. So in summary, health equity strives for the highest level of health for all, recognizing that subgroups might or usually require different supports to achieve that goal. We also know that health disparities are common and are the result of adverse social determinants of health, one of these being systemic or structural racism. In order to reduce disparities in health and healthcare, we must acknowledge, understand, and address the role of race in health and health outcomes. And I think one of the most exciting things or one of the few things that made me excited about 2020 and all that is entailed is the incredible kind of scene of anti-racism that we've seen within our own profession. So with the White Coats for Black Lives movement, we saw across the nation, physicians, nurses, other professionals coming out to support the concept of racism as a public health crisis. And what we recognized in this critical movement is that it wasn't just the Black and brown doctors. We had allies from every racial, socioeconomic, rural, urban background who understood that this was a problem that needed to be addressed and understood that at the health professional level, we had a role in here and that this was our lane. So that concludes the formal part of my presentation. I've left plenty of time for discussion because I think that is probably the most important thing for this topic. But I want to thank my division and the cancer center that I work in, and the funding sources that allow us to do this incredible work, and you, the audience, for listening to my talk. Thank you very much.
Thank you so much, Fola. That was outstanding and a really important discussion for all of us in medicine and in society. I want to encourage anyone to put questions in the chat so that we have an opportunity to have a discussion. But I'd like to start it off with a question, Fola. So in our field of gastroenterology and GI, liver, we have an issue as well with creating opportunities for underrepresented minorities. And in academic institutions, we who are involved in graduate medical education are seeing applicants from all backgrounds applying to our field. But sadly, it's a challenge sometimes to find the avenues to create more opportunities for underrepresented minorities. And obviously, we are a subspecialty of internal medicine. So we have to create opportunities for people to go into internal medicine, people to go to medicine itself. So it's a long pipeline that we need to work on. And I just wanted to know, from your perspective, how do you think people could be doing better? How do you think we as a field could be doing better?
Absolutely. Thank you very much for that question. The problem here is multifactorial in that you have this long pipeline, right? And the pipeline actually starts in elementary school and an interest in science, high school, getting the merit where you can go somewhere where you can study and do pre-med courses, getting into medical school, achieving that accolade, getting into internal medicine, and then having exposures to individuals, mentors, sponsors who are going to teach you about subspecialty fields and having the access to apply to them. And unfortunately, what we see is that the numbers are very low from the start. So when you look at numbers of African Americans who even enter medicine, they're lower than numbers of white Americans or Asian Americans. And even the people that go in, we've looked at the data, most of them are second generation physicians or nurses. So they've had some exposure, and that's the reason that they have picked the field. So I think that highlights that the first dropout in this pathway is that we don't have enough generation of an interest in science early enough for people to pick up that this is a career that is achievable for them. And I think that's the basis for a lot of programs that focus on elementary schools and high schools and trying to introduce STEM early and give students of color, kids of color, this notion that they too can achieve these careers. And one of the things I enjoy most, I just recently did a teen summit in LA where it was a bunch of teenagers and predominantly Black and brown. And they were just so encouraged to hear that they could go into medicine, they could go into nursing, that there were people who look like them in these fields. But they had very basic questions like, what tests do I need to take? What courses do I need to take? And the reality is the more affluent you are, you automatically have that information. So it's really about setting these people up in a way that they even can achieve those goals. And then at the training level, there are actually interesting data that show that debt is a significant contributor. So the average debt of a Black medical student is much higher than the average debt of a white graduate from medical school. And we think that that has a significant impact on willingness to do further training. So there's this concept that I need to get out. I need to get out and I need to start making money. And I can't extend my poverty by 3 more years. I might not have the family structure that supports it or even the resources, or I might even need to support my family. So we, I think, suffer in our subspecialty fields because we have to convince people who are already disadvantaged financially to sit back and take lower incomes for longer periods of time when they were hoping for glory days earlier. So it really is going to take us addressing med student debt, increasing more opportunities for students to go to med school, and in addition, giving exposure early in the medical school training, even beyond that, to make sure that people know that there are great opportunities in the field of GI.
Eric, can I ask a question?
Yeah, please jump in.
So I think clearly you've shown disparities exist. There are multiple factors that contribute. You've just mentioned 2 things in terms of training that we could do, I think, that are very concrete. One is mentoring and outreach to potential students, and the other is funding. And I think all of us could be involved with that. On a daily basis, though, in our clinical practice, we know that for our patients, these disparities exist, and so glaring to see the differences in colorectal cancer incidence and mortality. And as you've said, there are multiple upstream factors at play, but how can we on a daily basis in our own practice try to make an impact?
Thank you very much for that question. I am challenging every anti-racist ally to find one way in either their clinical setting, the setting in which they teach trainees, to address implicit bias or structural racism. And you can do this. You can easily do this. I heard the end of the IBD session, and I heard Dr. Melmed talk about having that list of the 5 critical patients that you're keeping a close eye on. Try and find the things that are happening in your own clinic that are making patients who have poor access, low income, more disadvantaged. And try to find a way to, as I said, interrupt that pathway. So if you are in a clinical setting where you are regionally displaced from Black and brown communities, is there a community health center that you can reach out to and partner to and give a talk about the impact of colorectal cancer on Black Americans? Is there a community health center that just needs someone to come in and talk about colonoscopy so that we can get rid of these fears and misinformations about the procedure? If you're someone who is training trainees, have a discussion with them about how race or their ethnicity or even their gender has impacted their experience in health and healthcare. You'll be shocked the stories that they share with you. And it will open your eyes to the kinds of things that we're dealing with in the hospital and the clinic every single day, and that we have to silence and kind of throw to the back of our mind. So I think that I ended by talking about some of the encouraging things that have come out of 2020. And I think I've had like almost tearful conversations with older white males who I didn't think understood it, but who have really had these moments where they've really kind of seen things through new eyes and have recognized the different challenges in providing care for disadvantaged populations, or even for trainees who are trying to be successful in our fields. And I promise you that everyone can find a way to do this just by looking in one of those 2 areas.
Fantastic. And I think one of the things that is encouraging, I feel, is the open discussions. I mean, like even this conversation in our major kind of Southern California GI meeting, to create opportunities for people to learn about how they can make a difference. And, again, as you've done, is open doors for other people to kind of think in this way. I think one question I had, since we were discussing colonoscopy screening earlier and these potential changes to the guidelines, although even if in draft form, it sounds like Dr. Levin was suggesting that they would become official. I think, how do you think this could potentially impact health disparities if we start screening everyone at 45 when we're already not screening enough people with the current guidelines?
Thank you for that question. I've been personally in such turmoil about all of this. I think, when USPFTF came out in 2016 and said we're sticking with 50, I think we all were a bit relieved because there really wasn't that much data about 45. And then the American Cancer Society really threw us all for a loop in 2018 when they recommended starting screening at age 45. And the reality is that the models, and I don't know if TR talked about this, but the models that the American Cancer Society used were quite similar to the models that the USPFTF were using. And I think what's happened now is that there's been more data. Now it's not randomized data, but it's observational data that does show that we're creeping down in age when you look at the incidence of not only the cancers, but the advanced adenomas. So I have kind of swung from someone who said, we need more data, we can't push this as a public health effort, to someone who actually, unfortunately, we're all seeing this in our clinics, but we're also seeing these data that you look at advanced adenoma incidence in the age band from 45 to 49, it looks the same as in some of the older groups. So something does need to be done, but I think we need to carefully weigh the implications of such a recommendation. And it's a draft form now. I think we all spent the month of late October, early November writing comments to the USPFTF, and they're wading through those now. I do think in the next few months it will be final. And so our goal is to understand how to make it happen. Unfortunately, USPFTF cannot take into consideration cost. They can't take into consideration resources. For those of us who work in health equity, we're horrified because I work in federally qualified health systems where the screening rate is 20 or 30%. 20% of age eligible people getting colorectal cancer screening. And now you're going to tell them that they also need to screen people who are 45 to 50. The implications for that group, just on cost alone, on resources, on educating their providers in an already stretched thin system, are very concerning, especially when we start talking about things like getting rid of the ACA or healthcare reform, which would have devastating impact on federally qualified health systems and community health centers. So I see why USPF went this way. I see how the modeling and observational data led to the recommendation, but I think what we need to do is recognize the resources that are going to be needed. And there needs to be policy, there needs to be action at the government level, I think, to actually achieve the goal. You can throw out recommendations every day, but if you don't actually provide the resources or the mechanisms to get there, you actually just set yourself up for a public health disaster and worsening disparities. And that's the biggest concern for those of us in health equity.
Fantastic. Gareth, do you have any other questions? Okay, well, great. Thank you so much, Fola. I don't see any other questions in the chat. So it looks like we'll get to our break and an opportunity to visit sponsors earlier. Thank you again, Fola, for your excellent talk. And I'm sure we'll be discussing this further in the future.
Thank you very much for having me. Everyone have a wonderful day and a wonderful weekend.